A very good morning, everyone. Welcome to Room 8. We are talking about childhood cancer. So some of you might be new to the topic. Great opportunity for you to learn about the unique opportunity to cure childhood cancer around the world. We've got a great panel for you. Expert speakers from different organisations. My name is Julie Torode and I'm a trustee of World Child Cancer, the co-host of this event, along with our partners, AMGEN. So I will run through the agenda today. We're going to have a great introduction to childhood cancer for those for whom it's a new topic, from the CEO, the new CEO of Luke Thomas of World Child Cancer. For those of you that haven't met Luke, great opportunity to meet him. Kathy Pritchard-Jones, I think you all know Kathy, will be talking about barriers to change in childhood cancer globally. And then we're going to look at a deep dive in Ghana, one of our long-term partner projects for World Child Cancer. Oh no, sorry, I'm jumping. Sorry, it's an early start for me. First, we're going to talk about the big ambition to show you where we are heading as a community in cancer and in childhood cancer with Kath Lam from St. Jude. And then we're going to have the deep dive. How do we take the reality of today and work towards that ambition? And we've got Dr. Lorna Renner from Korle Bu in Ghana talking about the work in partnership with World Child Cancer and others. And then we're going to have a bigger picture view from Zainab Bagudu from Nigeria, UICC board member, talking about paediatric cancer in low-middle income countries. We'll then break into a panel discussion, and I'm really encouraging you to note your questions as those talks are going on, because it's going to be an interactive panel discussion. So we'll have the speakers, as you can see, talking about the road to 2030. So the next 5-6 years, what can we do to make a big change? And we'd love your views on that as well. If you're timid, you don't want to talk into the mic, you can also share your questions by scanning this QR code and putting in your questions using the Mentimeter app. We'd love to have your ideas, thoughts and topics that we haven't had time to cover today, because we'd love to look at what you've sent in to us after this session as well. So if you want to use it just as a general input, very welcome to do so. Everyone scanned? Just want to make sure everyone's happy. Once it's gone, it's gone. Okay, no shouts of concern. So I would like to invite then Luke Thomas, the CEO of World Child Cancer, to make some introductory remarks.
Fabulous. Thank you, Julie. So I'm Luke Thomas. I'm the CEO of World Child Cancer. Cancer is a leading cause of death for children and adolescents around the world. However, it is forgotten or very poorly supported in many countries. That is essentially the reason why we have a greater than 80% survival rate in high-income countries and often as low as 20% in low-income countries. That's the reason we exist. We've grown since 2007 to be supporting cancer treatment for children in 13 countries around the world. So effectively what we provide is local leadership, but we try to provide that in a way which is globally connected. So we work with local expert partners to assess and address local challenges, which are context appropriate, because the way that you treat pediatric cancer in UK or Geneva, for example, might be very different to how you treat it in many of the countries in which we work. We bring international best practice, learning and resources to the table, but we also look to bring the collaboration of international initiatives, international partners like AMGEN, to work together to address the policy issues which are actually affecting better childhood cancer care in those countries. And the way we do that is through comprehensive support. It's not about improving one little area of the work. It really is trying to provide that comprehensive package, because if you don't address all of the issues affecting it, you're never going to solve the challenge. So the way that we do that is by raising awareness of childhood cancer, by improving access to early diagnosis, and there's lots of different ways we go about that. Improving the quality and access to treatment through funding some of those treatments, through training healthcare professionals, so pediatric oncologists, pediatric oncology nurses, pediatric oncology pharmacists, etc. And then we provide what we call psychosocial support, which I'm sure many of you will be very familiar with. But this is a mixture of the care and support, which is essential to good recovery for children from childhood cancer, as well as financial support to ensure that children and families don't abandon treatment. And I know I've used the word abandon. I know some people find abandoning treatment a term we're not super comfortable with, but we're yet to come up with a better one for the moment, so we'll go with it for now. So we take a system, family and child-centred approach, and for global initiatives to work, the national healthcare system needs to be effective, which is where World Child Cancer comes in. So a very quick bit about the epidemiology. There are about 400,000 cases of childhood cancer, new childhood cancer cases every year, the majority of which are in low to middle income countries. Now, about 50% of those children will never receive a diagnosis. Each individual childhood cancer itself would be a rare disease, but they're collected together. They're still extremely uncommon. But every child lost is a tragedy. And in fact, if you consider that 80 to 90% of survival rates in high-income countries, actually, I say it's more than a tragedy. I think personally, I think it's a disgrace. The 6 most common types are acute lymphoblastic leukemia, Hodgkin lymphoma, retinoblastoma, Wilms tumor, Burkitt lymphoma, and low-grade glioma. Now, there are obviously, of course, others, but those are the 6 leading causes of childhood cancer. One of the big things about it is that it is enormously survivable with good treatment. I say 80 to 90% of children should survive, but the key to that is early diagnosis, which is one of the big barriers to getting effective outcomes in low to middle income countries. So that survival rate I mentioned earlier, so as low as 20% in some low income countries, in some sort of low to middle income countries that can be as high as 30%. So it varies country to country depending on the context. But I'd say one thing that is fairly consistent is that around 50% of children go undiagnosed. And I think that is one of the things that we absolutely must address as a group to try and solve that. So the percentage, so about 79% of high-income countries have a national cancer control strategy, but only 31% of low-income countries have one. And I would question what percentage of those are actually active at any one time. Of this, 89% of high-income countries had national coverage for their strategy, but that drops to 22% in low-income countries. And these are figures from the 2018 figures from the Journal of Global Oncology. One of the things we need to do to actually move the dial on this is to increase awareness and funding for pediatric cancer. If you have parents, clinicians, and government who aren't aware of the challenges and the treatability of pediatric oncology, the parents don't seek care, the clinicians don't have the training they need to address the problem, and the government doesn't invest. So what we've achieved in countries like the UK and Switzerland and US, etc., has taken years and years of investment in the medicines, in the healthcare professionals, in the system, and in the data to ensure that what we're measuring and what we're doing is evidence-based and we're actually addressing the issues as they actually are. But we've also invested in the infrastructure, and this is something the World Child Cancer is doing a lot. So as I mentioned earlier, we spend a lot of money and time training the pediatric oncologists, the pediatric oncology nurses, the pediatric oncology pharmacists rather. But we've also started training a new cadre of people who are called child life specialists. And these are really important parts. They work with children through things like play to help them understand what they're going through, but also to help them make sure that they feel better about what they're doing, so that they tend to stick to their treatment better and they can overcome the challenges they're having. We also need to invest in the equipment So when I talk about infrastructure, this is not just, the people, but we actually, a lot of the countries that we work in, for example, there are no safety cabinets for very, very dangerous medicines. So the nurses, while they're treating children, are themselves getting sick from dealing with medicines ineffectively. We also, of course, need to improve the availability and accessibility of effective treatment. And this is something you'll hear a lot over the course of this week. And Catalan will talk about one of the fantastic global initiatives to address this. But there is a penalty which low to middle income countries face. They often get access to lower quality medicines or medicines without enough of the active ingredient. So that effectively what's being prescribed to children at that point, if it doesn't have enough of the active ingredient, is hope and a death sentence. And that is just not acceptable. So, as I mentioned, one of the key ways to do this is to improve this is the use of data. Improving use of data registries, as I mentioned, in high-income countries has been a foundation of improved outcomes. 95% of high-income countries use a cancer registry, 61% in low-income countries, and I would be very surprised if many of those were national registries or were being used as effectively as they could be. Of course, problems still remain in high-income countries. One of there's still challenges tracking survival rates over 5 years, even in the UK, where I live. But in many of the countries where we work as World Child Cancer, we'd be lucky to get 1 to 2 year survival rates. It's really hard to track people, but we have to get the data to know if what we're doing is being effective. Okay, so you're all caught up on childhood cancer. I'm going to hand you over to my fellow presenters to talk you through the challenges, the global ambitions, and the reality in the countries in which we work. Kathy.
Thank you, Luke. So I was given the somewhat negative title, Barriers to Change to Address. I always don't like to talk about negatives without really thinking about the positives and the solutions. And I think one of the things about barriers is you have to be able to kind of look them in the eye, understand them, see where the weaknesses are and how you're going to get over them. And sorry, someone said I need no introduction. I'm sure I do. I was the president of the International Society of Pediatric Oncology. I'm a semi-retired pediatric oncologist, and I'm still very active in doing research on Wilms tumor genomics and cancer survival data, international benchmarking. And I have a presentation on that tomorrow if you're interested. So I think when a family has a child diagnosed with cancer, it's not just a bump in the road they've got to get over, which this bridge is meant to show, but you could see there's a chasm running through or a huge mountain to cross. But basically, there's a very complex and interrelated elements of diagnosis, care and supportive care that are absolutely essential for effective treatment and care and any hope of cure at all. And they're all interdependent. So when you start at the left-hand side, if you don't get diagnosed on time, you turn up with disease that's inoperable or, too advanced to respond to chemo. Even if you get to a state-of-the-art diagnostic and treatment centre, your chance of cure is very low. But equally there's no point having an all-singing, all-hanging, dancing diagnostic and treatment centre if it doesn't have appropriately trained staff. And it needs to have access to core facilities like pathology, surgery, radiology, pharmacy services, all of which can have workforce within them who understand the specific needs of childhood cancer. And we heard in the plenary session this morning about the importance of including cancer in universal health coverage. And this has to be a holistic approach to treating not only the individual child, but the whole family, because having cancer in a sibling and for the parents has massive impact. So I'm not going to read through these, but I just thought I'd point out, again, some of these essential elements within the pathway. Early diagnosis is still a major issue that's lacking in many countries, but even if cancer's suspected, you've then got to have a very efficient and timely pathway to an appropriate place to make an accurate diagnosis, because so much of childhood cancer effective treatment is based now on accurate risk stratification, which determines what type of therapy to give, how strong it will be, how long it needs to last, etc. And a continuous availability of essential medicines. Now, paediatric oncology certainly in the higher income countries, has a very long history going back multiple decades. The access to clinical trials for newly diagnosed children with cancer has been seen as kind of standard of care, because the major disease-specific clinical trial groups offer inclusion in a clinical study, which is continuously trying to optimize care. Now, that might be introducing a new drug, it might be increasing therapy for the higher risk groups, it may actually be making no changes at all to the standard of care treatment, but collecting additional information on biology, imaging, etc., to look for new biomarkers that might help improve things. And of course, linked to clinical research, if you've got the staff to do it and patients are enrolled, is you get the outcomes because you follow those patients and you get the data. And I think also very important in both treatment and research is having parent and patient involvement, and making it in research and service improvement design, and ensuring that the survivors are very well informed about their health risks. Workforce, I'll come on to that in a moment, and of course the centres of expertise. So what are the barriers? I think tackling late diagnosis is a hugely complex issue. As I explained, it's all very well getting the parents to come to the primary healthcare facility, but if the people there don't understand that childhood cancer exists, or they think it's not curable, they may deprioritise sending them on, or they may say, well, go and try some alternative therapy first. Also, without proper cancer registration, you don't really know what burden of disease you're dealing with in terms of numbers, but also, very importantly, stage at diagnosis. For treatment, I think it's very important to be able to achieve a sort of national cohesion in how you address paediatric oncology in your country. Childhood cancer is still a rare disease, and people, especially in low middle income countries, may have gone to multiple different places to train outside their country, but if they come back and want to form a national society, you've got to get consensus building and that relationship with the Ministry of Health. And I think we all know how difficult both of those things can be. And then there's the opportunity to establish partnerships with people like World Child Cancer, many other NGOs and academic outreach and philanthropy. But again, those all have their stories and their boundaries and their ways of working. For workforce, I think a major barrier is specialty recognition, because there's so much information that you need to know as a paediatrician if you're going to treat children with cancer effectively. And it's usually the paediatrician background who becomes more and more of an oncologist who sort of holds the family's hand all the way through. But they need to be able to pull in all the members of the multidisciplinary team, the surgeon, the radiologist, the pathologist, the pharmacist, the physiotherapist, the child life support people. And the issue at the minute is that many of these specialties are not recognised by the professional qualification bodies in their own countries. And then, of course, you train people, it happens in every country, and they see career opportunities overseas and they want to perhaps move on and they may not come back. So we have to address that. Ministry of Health prioritisation for resources. The money will never be enough. So we need to, build our services to a way that we can have the outcomes and show we're effective. But again, that's a difficult thing to do. So it's a barrier. And there perhaps is an over-reliance on civil society organisations that takes the pressure off the Ministry of Health to be actively promoting activities in childhood cancer. So barriers to cure. This is Scott Howard, who's in the audience, created this diagram. It's a very oversimplification, but if you look on the left, these are the various categories why treatment might fail. And on the right, you see a sort of layout of how those things rank. I think this is mainly illustrated by Burkitt's lymphoma, which is a fairly highly curable cancer. If you get it, you don't even have to get it early. You just have to have effective treatment. But what you'll see is that where most of the children with cancer live in the world, and it's over 90% in any upper and lower middle income country, but it's still about 85% are in low and lower middle income countries. No diagnosis and treatment abandonment, this term that we'd love an alternative point of view word for, rank first and second respectively as to why treatment fails. And then you'll notice that incorrect diagnosis, which means you'll get the wrong treatment or an inappropriate treatment, and relapse are ranking third and fourth. So how do we know these children are missing? Well, we don't. It's all estimates. And until countries actually put in place means to count the numbers of children with cancer in their countries, we won't know. But this, again, is an estimated incidence deficit gap, if you like, of childhood cancer in the world. And you see that most of the countries where they're thought not to be diagnosed routinely are in sub-Saharan Africa and parts of Asia. Now, cancer registration at a population level obviously takes resources, but if you look at it from a health impact point of view, it's actually highly efficient investment by a Ministry of Health. But it's also sometimes seen as a nice to have rather than essential. This is a map based on data in 2007. I contacted Eva Stelio-Rover-Fouché at IARC and said, Eva, can't you give me an updated map? And she said, nobody else, no improvement that have passed the quality check since then. So this is what her view is. But what you'll notice is, for example, in Latin America, a recent survey by PAHO suggested that the coverage is now up to 24% in that area. But notice in Africa and Asia, where those excess and missing cases are, it's still very, very low coverage. So most of these data are estimates. But I want to move now on to how we're going to get over these barriers. So WHO and IARC are supporting the Global Initiative for Cancer Registry Improvement, and there's a specific one for children that Ava at IARC runs. And you can see these are the things that they offer. And they attend the impact workshops organised as part of the Global Initiative on Childhood Cancer when they're held in focus countries. Now, through that GICR in Central America, what you'll notice is that several cancer registries have started to improve their work. And in fact, 2 new paediatric registries were instituted in 2014 with support from St. Jude, Dana-Farber, and HOPCO is a professional organisation. And they're now registering, you can see quite significant numbers, 350 and 170 patients a year. They're in cities, but it's in, I think it's Guatemala and El Salvador. And what's really important, and this is all published, is that having set up those registries, they've been able to show that the GloboCan estimates that are what most of the world's data on childhood cancer is based on now, actually under-recording the true incidence, which has now been counted and measured in those population bases by about a third. So this is really important evidence about what the barriers are and how you can overcome them. Another important piece of work supported by that global initiative was to look at survival, stage distribution at diagnosis. And the point here, the poor donkey being pulled back by the burden of disease. But what you'll notice is these are 3 sub-Saharan African registries based in cities, but they've got population coverage. You know, more than half of the children are presenting with metastatic or very advanced disease. So starting from a bad place, this is the evidence you need to say we've got a problem with early diagnosis. Now, it's important to measure survival by stage, because if you can get the children early and give them appropriate treatment, then they should have a chance of having a really good survival rate. And again, that same effort looked at short-term survival, and you can see that for localised tumours, this is the data for Wilms tumour, you know, they're over the 60%, which is already the aim of the global initiative. Now, what about treatment abandonment? We don't like this term, but it is a sort of, there are multiple reasons why children and families may not be able to continue potentially therapeutic therapy. And this is a telephone audit of 85 families from Tata Memorial Hospital. And you can see these are the reasons. And the commonest are, in fact, preference for alternative medicines, financial constraints, and anxiety, and false beliefs that childhood cancer is not curable. So it tells you that you need advocacy, education of the public, etc., to overcome this barrier. And what they did in this study, so they introduced enhanced tracking in 2012, And you'll see the refusal to initiate treatment and abandonment together have dropped from 20% down to less than 5%. And that's been sustained over several years since they introduced that. Workforce. This is Professor Joyce Kamburu in Kampala, Uganda. We were there for a South Africa meeting, and this is their new radiotherapy machine. But, you need trained specialists across the multidisciplinary team. And we're always competing with the general workforce shortage in LMICs. Nurses often have a requirement to rotate through specialties. When in high-income countries, you'll get nurses who can dedicate themselves to paediatric oncology for their entire career. I know that once people are trained, particularly, they may have to move abroad to earn enough money to support their families because government hospital salaries are often too low. And again, getting the recognition of specialist qualifications by the national professional councils is really important. And as we saw in COVID, sometimes the oncology nurses who know how to give IVs and so on get diverted to other areas. And of course, clinical research integration needs resources and is very important. So we need advocacy at all levels. We need inclusion of childhood cancer in the National Cancer Control Plan with specific resourcing. I would urge any country that's looking to improve its childhood cancer services to create and maintain a national professional society working with the Ministry of Health. And then there's a lot of work to do together at a national level. We want to be advocating for diagnosis as well as treatment of cancer to be part of universal health coverage, holistic family support. And as we heard yesterday at a WHO meeting, there's a lot of work to be done on ensuring parent and older childhood cancer patient meaningful involvement in care improvement and research. This is the situation in the UK. Back in the 1980s, we had a single protocol book for solid tumours. But, you've got to keep abreast of all the treatments. We now have a national society. Everything's online. And in fact, we're mostly part of European tumour study groups. And there's a huge amount of information that the doctors and nurses need to understand and know. And just to emphasise, this all takes time. This is the situation again in the UK, that it's taken almost 30 years to go from 60% to 84%. But this is national population-based cancer registry data. So I'll just finish by saying that we do have a solution. It's called the Global Initiative with a CureALL framework, and we're going to hear a lot more about that in the next presentation. Thank you very much.
Good morning. So it's a privilege to share a bit more. As you've been hearing today, there are a lot of ways to win, and we have big ambitions to do this together. My name is Kath Lamb, and I'm a pediatric oncologist from St. Jude Children's Research Hospital. And a lot of our inspiration comes from the wonderful collaborators that we work with more than 300 collaborating hospitals and more than 80 collaborating foundations as part of our St. Jude Global Alliance. We really believe in big ambitions and how we might achieve it together with our friends from World Child Cancer and SIAP and CCI and so many of you around the room. No relevant disclosures, and as you heard from Kathy, we really have seen a lot of progress just in the past 50 years. And this is really a grounding context for us, just to think that about 50 years ago, we were still looking at childhood cancer, including the most common childhood cancer, acute lymphoblastic leukemia, as not being curable. And how incredible it is that we have this complete turnaround, and what an inspiration and what a foundation for us to have big ambitions, so that we can really see something that used to be completely untreatable to something that we should and must tackle together, and be able to see this transform not only for select populations, but for children and adolescents everywhere. And so as we carry this forward, thinking it went from 9% survival to 90+% survival, how do we make sure, now that we've seen what can be done, how do we make sure we translate these ambitions into reality, and with the known solutions in hand, make sure that we are reaching the most in need? In this case, meaning that we reach most of the children, and most of them are in low and middle income country settings. And especially when we see that most children still experience survival closer to 20% rather than 80%, there's a lot of opportunity And this is why we have reason for hope and reason to be as ambitious as we are. We also want to make sure that we are grounding our ambitions with the end we have in mind. And that is very much from the perspective of those with lived experiences and living experiences. And in the words of those who have gone through cancer, we always hear it's very much about quality of life. So we have to keep that in mind and to recognize that no child and no family is ever by themselves. In this beautiful depiction from one of the adolescents in the Philippines, they drew this figure where there's a bamboo being carried by a whole community, and it's a whole community that may be experiencing childhood cancer together, and it has to be carried forward together. That's one person is not enough, and it's also not the experience of one person. Increasingly, we're seeing the appreciation of United Nations partners and having our advocates at the front lines, and we hope to see even more of this moving forward. They are the champions that will tell us how to continue to lead these ambitions and to achieve these ambitions. All of this grounds us in why we were so committed at St. Jude to work with WHO over the years to really translate these inequities and to make sure we can bridge these gaps. And just a few years ago, I think there would have been many doubters saying that it was not possible to have childhood cancer be featured at the United Nations. And we have since been able to achieve this twice together with many of the wonderful partners in this room in 2018 and again recently in 2023, showing and demonstrating why childhood cancer really belongs in the global agenda. We partly started this work multiple years ago, and we're invited to be the first and only WHO collaborating center for childhood cancer at St. Jude, and supporting specifically national cancer control planning, as well as innovation and research and education, as well as bringing collaborators together so that we can have technical collaboration as well as fostering stakeholder engagements. And we realized that as we were working together as a collaborating center, there was a lot more work that needed to be done. And that was what formed the seeds for St. Jude providing the technical and the financial support, and then working with many partners to develop the global initiative for childhood cancer. And already we've invested more than $16.5 million to make sure that we can successfully launch and implement this global initiative for childhood cancer that now engages 77 plus countries from all regions of the world. There's a lot more to be done as we think about how to save 1 million more children by 2030. And as you also heard from Cassie, it's really important to speak the same language, not only as clinicians, but as a global community. So actually a few years ago, right in this very convention center, we were presenting with WHO on how to redefine the health systems framework that you see on the slide. And we developed what we now call the Health Systems Plus framework, so that we would feature children in the center and make sure we highlight the role of family and community engagements alongside the very critical roles of service delivery and workforce and information systems and medical products and technologies, including diagnostics and radiation therapy, and then, of course, financing and governance. And then linking to this Health Systems Plus framework that we've been using throughout all the years since then, we then adopted this as we developed the CureALL framework. So you'll see it's not by chance that, for instance, when we look at the orange color, we're always seeing essential diagnostics and medicines and technologies and regimens for management. And then the same orange carries through when we're thinking about the 10 CureALL core projects, so that we can start to recognize that there is a very important role for multi-sector and multidisciplinary care and management as we think about addressing the gaps and reaching the big ambitions for children with cancer. Expanding a little bit more on these 10 CureALL core projects, you can see across the bottom, the foundation, many global partners. And this means that no one pursuing these projects ever has to be approaching them alone, but that there is a broad community and a lot of existing resources, including in the vertical, just as example, global public goods that we offer through St. Jude Global for partners and collaborators to work on and develop these together. So whether this is in the analysis of the cancer health system that cuts across all dimensions of the CureALL framework, or a national cancer control plan and strategy implementation, or in red, linking to the C pillar of looking at centers of excellence in referral pathways and implementation of workforce packages. There are lots of existing resources that we can amplify together. It's also really important to make sure that we're not only just talking amongst ourselves. We see a lot of friends in this room and a lot of those who've been spending your life energy on advocating for childhood cancer. What we would love to see is to continue to have childhood cancer embedded into rooms and into spaces that previously would not have included childhood cancer. And this includes rooms that are having the big conversations about sustainable development goals, about improving access to medicines for the next 1 billion, conversations about how to make sure we're achieving universal health coverage. So it's up to all of us to make sure when you're in the distinct rooms that you are able to carry your voice into, how do we make sure that we show the advantages of embedding and integrating children with cancer? We've also seen just over the past few years the first ever inclusion of childhood cancer into various UN reports, including additional expansions into the first WHO essential diagnostics lists, the WHO report on cancer with dedicated components for childhood cancer, as well as through the coordination of IAEA impacts reviews that now for the first time headline childhood cancer alongside breast and cervical cancer. There are also now fact sheets for childhood cancer featured through WHO, as well as the entire CureALL suite of tools and resources, and lots of active working groups through different UN agencies where we can see the threads of what's needed for childhood cancer alongside the spectrum of what's possible for non-communicable diseases and for child health. We know that when we had this first WHO cancer profile in 2020, unfortunately only a fifth of the world reported having early referral pathways or guidelines for children and having a referral system in about a third. And only about half said they had an operational cancer control plan or having palliative care generally available. And those numbers drop quite dramatically when you talk about childhood cancer specifics. So there's a lot more work to be done for us to embed childhood cancer, and this has to be done across all levels, whether we are at a global level or at a regional, national, hospital, or programmatic level. And this really does, again, require all hands in to achieve this. This is a really good time, especially as we look ahead to the first ever global status reports on the triple initiatives of breast and cervical and childhood cancer in the coming year, for us to make sure we're all doing our parts to make sure there's relevant data being captured. And this has to be at both the hospital-based and population-based setting. And this is why St. Jude also developed a separate agreements with IARC with both financial and technical support for child GICR to make sure we can get relevant childhood cancer data for ages 0 to 19. And St. Jude Global also offers dedicated free training and resources and a platform for data capture that enables the data to be used across all settings. So this is really, again, about integration of data that's usable and making sure that at the end of the day, we can step back and make sure that we leave with the message that it's not just about diagnosis and it's not just about improving access in the very beginning. As you know, we generally cannot prevent childhood cancer. So our focus has to be preventing what is preventable, preventing the suffering, preventing the morbidity, preventing the mortality. And if we do not do anything, you can see the flat line there where we're still going to be at about 20% globally between now and 2050. If we invest just in early diagnosis or just in treatment abandonments or just in access, we can barely get that up to 30-40%. But only if we invest comprehensively from diagnosis through to treatments, through to treatment completion supports, including all the resources the families may need through their long months of treatments, do we get closer to the purple line, which is what we all want to see, closer to the 80% survival. And what's important is that when we invest this way, not piecemeal, every dollar invested results in $3. And so it's $3 in return. And so it's cost effective when we think about this core package of interventions for children with cancer. But we have to think of it as a holistic approach. And this is what magnifies health benefits. And while we know that many have been emphasizing decentralization and we love working with our primary health partners, At the same time, we know that childhood cancer is a specialized, rare condition, and it does not make sense to have everything be offered in identical ways in rural communities or in primary health centers. There has to be tiered packages of core interventions so that we can make sure we're both being efficient and effective and effectively supporting the strengthening of the systems as a whole. So we hope that you will all continue to be champions as we think about how to do this in a sustainable way, as we illustrated and have ongoing work as part of this Lancet Oncology Commission. And one of the things we certainly realized over the years is that there are some things that we simply cannot do alone as a hospital or as a team or as a program. There are some things that we have to tackle as a global community. And this is what motivated St. Jude to work with WHO and UNICEF and PAHO Strategic Fund to develop the global platform for access to childhood cancer medicines. And this is the first unique global fund of its kind for non-communicable disease. So there's a lot to be learned. And over the past few years, we've been working very hard to co-design the process with one country from each of the 6 WHO regions. And we're excited to soon be welcoming the next wave in the cohort of countries to join us in this co-design process, so we can set up something that will be truly transformative as well as sustainable to ensure quality medicines for all children and adolescents who are in need. We do not have time today to walk through all the different ways to win and all the different ways we can achieve these grand ambitions. So we certainly hope for those of you who are advocates and are passionate about sharing your expertise, whether you're working day-to-day in adult cancer control or in childhood cancer control, that you will join us in this NCCP ICAIA. So NCCP ICAIA stands for National Cancer Control Planning, Integrating Children, Adolescents, and Young Adults. And we started this a few years ago with our friends from National Cancer Institutes, US, and ICCP, with our team at St. Jude. And we are really committed to working together to facilitate the cross-exchange of ideas. And this is really a ministry-led effort. And we've now invited, for this current cohort, 21 ministry-led teams from all 6 WHO regions. And they will be graduating and having their capstone session later this month. So if you would like to join us, the QR code is there, and then we'll be welcoming the next cohorts for the coming year as well. As we think about how to achieve this ambitious targets together, we also have our Nexpos, Nexus of Policies and Systems. We heard from our collaborators that many times we have disease-specific briefs for leukemia, for Wilms tumor, for brain tumors, but there is nothing cross-cutting that allows us to talk about the big challenges, the big solutions, the big ambitions, and how to achieve them together. So please invite your young investigators or your senior ministry collaborators or yourselves to join us to troubleshoot through how we might tackle these challenges and ambitious, game-changing, transformative efforts in new ways through our Nexpos networks. And then my email address is here for those who would love to share additional collaborative insights and ideas, as we really believe that we can only do this together, and together we can have all hands in to advance these ambitions to make sure these are reality. Thank you so much. And now you will hear from Professor Lorna Renner, who is truly a champion from Ghana and who will tell you all about what it means to translate ambitions into action. Thank you so much, Lorna.
Thanks very much, Kath, for detailing so clearly the what policymakers expect of us. And so now I would like to take you through, as an implementer, what the reality sometimes can be. Thank you very much. Okay, so I'm from Ghana, Accra, Ghana. So it will obviously be based on the WHO CureALL framework and the core projects which are useful in terms of assessing one's progress. So how did we start? We became one of the first UICC-focused countries in 2019 and in Africa. And we had a stakeholders meeting in November of 2019. It was quite a comprehensive stakeholders meeting. I think maybe you might be able to recognize a few people here, including Scott somewhere. I don't know where he is. Yes, somewhere up there, yes. And others here. Quite comprehensive, both local and international, with Ministry of Health, academia, clinicians, etc. And following on that, we actually did an assessment of the nationals, the service in terms of childhood cancer. And then we developed a steering committee for childhood cancer. And we worked on a national childhood cancer strategy document. We do have a national cancer document, but they're working on that. But we couldn't wait for them to complete it. So we came up with this document with the goal in line with the UICC goal of 60% survival rates by 2030. And we included that at least 80% of all children with cancers in Ghana have access to care by 2030. And the main objectives were strengthening governance for childhood cancer, awareness creation, building capacity for cure, and promoting research. And I'll take you through what we've done with regards to this. So let's start with awareness creation. That's been really important in improving our outcomes in terms of early diagnosis. So you need to make the population aware as well as healthcare workers. So posters and training materials were developed, and we worked in collaboration with the Ghana Health Service and Ministry of Health. And we've trained health workers in all 16 regions of Ghana with the collaboration of World Childhood Cancer Society of Ghana, and the Ghana Health Service as well. And we've produced various animations, jingles, and we've had quite a number of media engagements for the general public. And up here, I was at a district hospital a few months ago, and I was really pleased to find one of our posters in the district hospital there, which shows that the government has really distributed these posters all over the country. Yes, and this is another poster of ours. And you can see one of the nurses doing a training for the general public here. And this is one of the trainings that were undertaken in one of the regional centers. We've also been undertaking talks in marketplaces, churches, and schools. You can even see the school students engage themselves. They were doing a fundraising, so they had T-shirts, Save a Child with Cancer. They walked the streets, and yes. So, and also, apart from when you raise awareness, you have to be prepared for the increased numbers of patients that will come in, yes. So you need to also train your cancer workforce. We've got a training program for pediatric oncology training, and that's also supported by World Child Cancer, which you can see the things that World Child Cancer covers. And a number of our workforce have also been involved in the St. Jude Global Scholars Training Programs, which is also very broad-based. And then we also have training for pediatric oncology nurse specialists, a 1-year training program, and also pediatric oncology pharmacist. So the training is multidisciplinary, in addition to other trainings that I'll show you. And the pictures just show some of our trainee pediatric oncology fellows, and these are the nurses as well. As I was saying, the training is multidisciplinary. So we have a foundation nurse training course, which is a 1-week course, which is done on the wards for new nurses to orientate them to pediatric oncology. And also, because we've opened shared care centers to improve access to treatment. So for the shared care centers, multidisciplinary teams, nurses, doctors, pharmacists come to the major treatment centers, and they spend a month to 2 months there to acquire some knowledge and skills, and then go back, and they're able to take on some of the minor aspects of pediatric oncology management. We also have twinning workshops twice a year involving the POUs and the shared care centers, and we get some facilitators from our training center in the UK. Our nutritionists have also been trained on management of malnutrition in children with cancer. And currently, there's a national-based palliative care training going on for the next 2 years. And we've also developed a curriculum for palliative care training. And importantly, it's been developed in the Ghana College of Physicians and Surgeons and the Ghana College of Nurses and Pharmacists. And it's supposed to cover all subspecialties. So even if you're an orthopedic surgeon, you should know how to institute appropriate palliative care for children who you may have to manage. Okay. And here you can see a radiographer training some other radiographers as to how to perform good ultrasound scans. And hand in hand with improving the workshop, you also have to improve infrastructure. So up here shows what our pediatric oncology daycare unit was before, and now what it is like. You can see the vast difference. You wouldn't have thought you could transform a place like that to here. So this is what we use for our pediatric oncology daycare. And this is a biosafety cabinet, which has been deployed in 4 centers in the country, courtesy of World Child Cancer. And we've also refurbished our pathology department with immunohistochemistry reagents. And it's not only World Child Cancer, but even local NGOs also sometimes support us with equipment and other things that we need. So this one shows to improve geographical access, because it's difficult for families to come all the way down to the treatment centers, which are mainly in the southern part of the country. We've got Greater Accra region, that's Korle Bu, the main treatment center. We've got Ashanti region, Konfanochi. Those are the 2 main treatment centers, and another one in Accra. The rest of the country, you could see, would have been devoid. But fortunately, with the support of World Child Cancer, we've established shared care centers here, all the way up north. So what we do is sometimes we start treatment, for example, leukemia in the Greater Accra region at Korle Bu. And then if they're from the north, we communicate with the center in the north so that they can go and have some of the less intense treatment there, and so as to try to reduce treatment abandonment and hardships on the families. And you can see, so prior to 2019, that's prior to the GICC, we had 3 pediatric oncologists and no specialist nurses. Now we have 10 pediatric oncologists and 1 and specialist nurses. Out of the 10 pediatric oncologists, actually it should be 7. 7 have been trained in Ghana. Not 5, 7 trained in Ghana. And this also the 10, and we've also trained 1 for Sierra Leone as well. She's back there working. And currently we have 17 trainee pediatric oncologists, 7 from other West African countries, Nigeria, Cameroon, Liberia. And also we have another one from Sierra Leone. And we've trained 29 pediatric oncology nurses with the help of Boston Children's Hospital. And we've trained 4 pediatric oncology pharmacists. Okay, and we're thinking of holistic care, as the other previous speaker mentioned. You can't just think about just treatment and reducing abandonment, but it has to be holistic support, psychosocial support, to be able to improve outcomes. So in addition to support for diagnostics, drugs, there's support also for patient transportation, and we also provide welcome packs on the ward for patients when they come in, new basic things that they would need, just in case they had to come in a hurry, like towels, toothpaste, a few other edibles and the rest to make them welcome. And then our First Lady, we've involved her a lot in childhood cancer, and she constructed single-handedly this hostel that you see, where we're able to give our families a home away from home for the full duration of treatment, whether it's 1 year, 2 years, or 3 years. They have free accommodation and free meals. And also, we know that there are indirect costs, like some families, they may lose their jobs, and other social costs. So we equip the mothers with income-generating skills so that when they go back home, they'll be able to at least pick up from somewhere. So you can see some of them involved in beadcraft and also in baking as well, which they really enjoy. And with the psychosocial support, we've got 3 child life specialists in the 3 centers in Ghana. And you can see the child life specialist with the children here. We've developed a parent information booklet when they come in new so that they become a bit more familiar with what's going on and who to contact. And also, we've got a clinical psychologist on our team and hospital school teachers supplied by the Ghana Education Service so that the children don't fall back in their education. And they've also been given extra training by World Child Cancer so that they can modify it to suit the chronically ill child. We also have an outreach nursing team, palliative care team. You can see they've gone to a very rural area here. And they also follow up patients who have missed scheduled appointments. And our trainees are not left out. These were developed by 2 of my trainee fellows for children so that they can make their stay a bit interesting. This about the scar, a child who had an nephrectomy, losing their hair, their pride, so that they don't feel odd or something like that. I'm not alone. So that gives them a sense of hope. And also, we've got a package for survivors. You know, treating children doesn't end when treatment goes. You have to follow up survivors. So World Child Cancer has established an educational grant for survivors so that they can complete their secondary school and go on to tertiary education, which they're benefiting from. So, yes, we've also developed national treatment guidelines, not only for the 6 index cancers, but for other childhood cancers as well. And we've developed supportive care guidelines suitable for all centers, including primary healthcare facilities. And we developed them for the primary healthcare facilities based on the IMCI approach, which they are more used to. So they're able to put it into practice. Yes. And to develop these guidelines, it wasn't only the pediatric oncologists, but it was multidisciplinary, so that we had the input of all other members of the team to make it most appropriate. And looking at, importantly, is medicines, the availability of medicines. That's somewhat of an issue in our country. We do have support from international organizations such as World Child Cancer, AMGEN, etc., for some drugs treatment. And also we have input from support from faith-based organizations and individuals to purchase the drugs. We're really looking forward to being part of the global platform for access to cancer medicines. Whoever is here who's in charge, I hope you've heard, Ghana is looking forward to that. We've applied for that. Okay, all right. And our national essential medicines list is based on the WHO essential medicines list. And when you're advocating, sometimes you always need good evidence to convince policymakers. So we undertook a cost-effectiveness, study in Accra and came up with a holistic costing, which included medical personnel, pathology, pharmacy, radiation, imaging, surgery, blood services, and even administration. We included everything. And we used that as an advocacy tool with the policymakers so that they would see how the economic benefits of having a good childhood cancer service and having it on the National Health Insurance scheme. So, and we also engaged the First Lady and other stakeholders. Unfortunately, in November 2021, 4 childhood cancers were put on the National Health Insurance scheme, and they included acute lymphoblastic leukemia, Burkitt lymphoma, Wilms tumor, and retinoblastoma. And those form about 60% of the cancers that we see. Okay. And we worked together, Childhood Cancer Society of Ghana worked together with the National Health Insurance Authority to do the costing and come up with a benefits package. Strengthening and linking cancer registries, that's been a bit of an issue. We're still working at it, hopefully with the help of St. Jude and others. We do have hospital-based registries with data managers supported by World Child Cancer. And the Kumasi City Cancer Challenge is a population-based cancer registry, and that was started in 2018, but that's only for the Ashanti region. And also, in addition to that population-based registry, they've launched an Uncle Kids app, where when a doctor in a primary health facility suspects childhood cancer, he quickly puts it in the app and then refers the child to the treatment center, so that the doctors there will be expecting the child, and they'll make all preparation. If it's blood transfusion services, if it's intensive care, they're ready for the child. If they wait a couple of days and the child does not show up in the hospital, they get back to the primary physician and as to what's happening, and they follow that up. And we hope that will be spread not only in Kumasi but to other parts of the country. We are looking forward to that with the help of the City Cancer Challenge. So what's the reality now? So as you can see, in 2010, before one of our major partners, World Child Cancer, started, we had only one center, which saw about 140 cases a year. Last year, we saw about 500 cases, which has gone up. So that's about more than tripled the number of cases because of the shared care centers. Treatment facilities, we had only one center. Now we have 3 POUs and 5 shared care centers for the country, as you can see. Human resources, we had only 1 pediatric oncologist in 2010. This year, now we have 10 pediatric oncologists with specialist nurses and pharmacists, and we have multidisciplinary teams in all the POUs. This is just showing the POUs, okay. And on your far, is it left? Okay, it shows what it was in Korle Bu before the assistance of World Child Cancer. Our abandonment rate was way up, about 40%. That was terrible. With the input support for transport, treatment, etc., accommodation, etc., it fell down to about 14% and sort of hovered around this. So it was hovering in the teens to about 10%. This is only Korle Bu. Now, when we had other shared care centers come on board, this one shows with other shared care centers since 2018, together the abandonment rate was about 14%, 15%. 2020 was the year of the COVID. You would have thought a huge abandonment rate. But you can see even the numbers went up. What we put in place was we kept a lot of the families in the hostel and were able to feed them. They didn't go home, but they were okay. They were taken care of. And we scheduled some of the appointments. Those who had to go were made not as frequent, but they were still effective. So we had abandonment rate actually went down and the numbers went up. And since then, I think it's gone up again. Abandonment has gone up again because now families are free to go home, and I think we need to find what we can do to improve, to bring down the abandonment as well. So it's not all that rosy, but what you can see is obviously the increase in numbers. You can see the increase in numbers from the 140 to now over 500 for the country. So that's, I think that's a plus for us. So we're still working on improving because, as you know, if children complete treatment, then there's an increased higher rate of survival. Okay, so I'll just look at what we've comparing to our national strategy. The ticks show what we've done a lot well. Governance, awareness creation, yes. Building capacity, we're still working on that. Promoting research and cancer registries, we're still working on that. And finally, looking at comparing with the CureALL core projects to showcase progress. This is just to assess progress on a national level. You can see 1 to 10. It shows those who've been involved, WHO, World Child Cancer, St. Jude, Ministry of Health. So it's been both local and international. And we've worked quite hard on almost all the core projects. 8 is to do with the cancer registries, which is a work in progress. Thank you very much. So I'd like to thank these partners. Thank you. And everyone. Okay. So I'd like to hand over to Zainab.
Morning, everyone. We've heard the deep dive into pediatric oncology, pediatric childhood cancers, and then specifically about what is happening in Ghana. It's we usually talk about the disparities, but it's very encouraging when you hear that the progress is being made. And as Catherine said, it can be made, and we need to focus on that. So my own task this morning is to talk about the policies, the advocacies, and the various ways in which we have been involved in improving cancer for children, the outcome in Nigeria specifically. I'm glad that we have the Director General of the Nigerian Cancer Research and Institute here. I was privileged to have seen some of my sister Lorna's slides, so I prompted him to listen closely in the hope that we will see some change as well. Generally, the approach globally is to develop and sustain governance structures that will give us results on what we're trying to achieve, a supporting dialogue across all the sectors so that we can strengthen the workforce and other aspects that will help us to increase access to cancer medications for children. And then, of course, engaging the pharma that produce the medications, as well as all the other disposables that you need to care for children. It's always a special problem caring for children because everything of theirs is different. So globally, these are all the things that have been done. There's also a movement to include children in clinical trials. We can argue about that and adolescents, but for us to have better drugs that perform better, we will have to look at that as well. In Nigeria, the picture is not as rosy, but we have been able to achieve some things, such as the inclusion of partners in the country. Now there is increased availability through these partnerships, one of which is the Chemotherapy Access Program. We've been able to increase access to pediatric oncology medication for leukemia and lymphomas in particular. The Cancer Health Fund initially was not covering pediatric oncology, but with the advocacy and persistent pull of some of us in this room, as well as the oncologists in the country, of which we have probably less than 10, but I think we had less than 10 at the last count. So for a country of that population is really quite small. But they're doing a lot of work. There's been also increase in diagnostic capacity. Like I said, it's quite difficult to work with children. One of the major barriers to diagnosing childhood cancers in our environments is the low suspicion of index from the physicians, and then you back it up, or should I say generally healthcare workers, not just physicians. And then when you back this up with the poor diagnostic facilities and ability capacities, it becomes even worse. But however, there's been concerted efforts through development of diagnostic centers, very high investment diagnostic centers. The government is trying to improve on that, as well as training. We've heard a lot about the partnership with St. Jude's. This photo is actually from the St. Jude's visit. The ALSAC Global Scholars, Marx Foundation, they're all working with the community to try to improve outcomes. It's becoming more structured because we have now the institutes that I mentioned, and there's a more focus and ability to partner with government through that institute. So the St. Jude's team, as well as Marx Foundation, have been working hard at that. I chair a group of ladies called the First Ladies Against Cancer, and in partnership with BioVentures Against Global Health, we have been holding some pediatric-focused programs, such as online training for oncology nurses with some modules for pediatrics, as well as development of educational materials so that we could distribute to some of the institutions, as well as advocacy groups. For us, the advocacy groups are quite developed, much more developed, I'd say, than the discipline, and they've been able to champion some change. There's Dorcas, quite a few of them are working hard in the space and improving awareness and advocacy. So again, Lorna spoke about the financial case and the modules and the cost analysis that they did. it's always very good to have your data and to be able to make a financial case when we're advocating for change in health issues. There are two aspects. There's the direct cost of the treatment of the medication. Then there's also the burden. For some reason with children, it's more difficult when you have cancer, because everybody has to go to the hospital. But with children, the associated cost is often more stressed on, and that tends to be much of a burden on the families. The average cost for leukemia is about $14,000, which somebody can help me with the calculations today. It changes every day. And when you compare that to the average income of the family, it's not a rosy picture. So without support, and till now, the national insurance does not cover childhood cancers, and without support, so patients have to pay out of pocket from individual donors, from NGOs, and philanthropic activity. So like I said, it's quite a grim picture. And if we're able to include that in our advocacy, it's helpful. And that is what we do at the Medicaid Foundation that I lead, as well as the First Ladies Against Cancer. A lot of awareness, a lot of patient support. There's only so much one can do in terms of the infrastructure. Is really a government issue, and training and capacity building for the oncologists and the healthcare workers. But we do a lot of patient support at the tertiary institutions like the University of Abuja Teaching Hospital, the National Hospital, as well as policy in the right circles to ensure that, like I mentioned, we were able to successfully advocate for the inclusion of drugs that children with cancer can use into the National Cancer Health Treatment. The fund, there's a health fund, Cancer Health Fund, as well as the Chemotherapy Access Program. Chemotherapy agents for childhood cancers has been included into the program, into the access program, but the fund we're still working on that, and hopefully we'll see that happen through this type of high-level advocacy. So these are just some of the images that of things that we do. Some show, I have a pointer, I think. Hello, Princess Dina. Thank you for joining. At the University of Abuja Teaching Hospital, the Federal Medical Center, Jabi, the Federal Medical Center in Jabi has received a lot of support from the Lions Club, and they built one of the few dedicated pediatric centers for oncology in Nigeria in the university. So we always like to support that unit, because whatever you do there is helpful. Like I mentioned, we developed some IEC materials in partnership with BVGH, and in 5 local Nigerian languages. They're targeted at the parents as well as the community health extension workers that are usually the first line to see these children when they're sick. So in conclusion, I would like to say that advocacy is key. We've heard so much evidence for the fact that childhood cancers are curable if the right resources are in the right place. I believe Catherine added at the right time, with the right team. We have to be intentional. Pediatrics generally, to do with children, you need to be intentional about the advocacy and including things that have to do with them in the front of the cancer care policies. Now the National Cancer Control Plan has a pediatric section, but initially this was not the case. Partnerships are essential. It is my hope that at the end of this session, we're going to be able to forge a unique partnership with World Childhood Cancer and the Nigerian Institute of Cancer Research, so that in 2 years' time, when I present this, I'll sound just like Lorna. I think that's my final point, and the need to, of course, invest. We must keep investing within country, outside country, for the progress to come. And this doesn't just stop at investing in the treatment that we need, but we must also look at clinical research and trials. Thank you very much.
Thank you very much, Zainab. And if you'd like to join our panelists here. So hands up, who didn't know about the 80-20 divide? Was it new to you? Some new advocates for the childhood cancer community down here. So we had a whistle-stop tour with our speakers, facing up to the barriers in low middle income countries, reaching out to the ambition. I love the looking back, because we have to remind ourselves, Lorna, don't we, where we were and how much we've already improved. And I think it gives us the inspiration to reach for the 2030 goals. So thank you everyone for your presentations. Hands up in the room, questions? Orange t-shirt here.
Okay. Thank you. Good morning, still morning. I'm Adeke Miriewusi. I'm from Nigeria. I'm a childhood cancer survivor and advocate. I want to say a very big thank you to you and also to NICRAT. But my question and basically suggestion is, how do we involve, we are now talking about having the experience or the voices of people with lived experience. So when we talk about stakeholder engagement, we realize that for childhood cancer, we are not a lot speaking. So how do we ensure that we engage those that are actually advocating and creating awareness on that? Also, the initiative from First Lady against cancer, how do we take the awareness from just, because we know a lot of our population do not read, how do we ensure that we go through jingles to create awareness, because it will go extra mile? And then also for the National Cancer Control Plan, I think that childhood cancer would be lost if we are not trying to specify the percentage of intervention that we want to give to childhood cancer. We put it on the umbrella of cancer intervention. I think that we need to specify. I'm a project manager, so I want to have indices. I want to see what the percentage of that intervention would be for childhood cancer. We're not just putting it under the general umbrella. Thank you.
There were a lot of things to unpack in that one. Let me go first to Cassie. Given that we together were at the meeting yesterday with WHO about engaging people with lived experience, what's your thoughts from the conversation yesterday about engaging particularly people?
Well, I think, the strong message is that WHO is putting patient involvement in cancer care improvement and design front and centre. The plan is to come up with a resolution. You were probably at the meeting yesterday. What impressed me is that the number of people there who were actually childhood cancer survivors themselves or had been a caregiver or advocate for childhood cancer. So I think, as you yourself demonstrate, it's a disease you can put behind you and be there to advocate. And perhaps before I pass to Lorna, just one comment about how do we involve patients and carers in care improvement and research. I think it's absolutely fundamental. I know in Jordan, for example, they did a fantastic campaign on early awareness of childhood brain tumours, where they involved the whole communities and school children, but there were a lot of childhood cancer survivors themselves involved in doing that work. And I've seen, I'm going to pass to Lorna because she's got the lived experience of involving people in Ghana.
I'm sorry. Hello. Yes. Okay. So yes, you can involve them in several ways. Creating awareness, like we do have. Creating awareness. For instance, just this past launch of our International Childhood Cancer Month, we had 2 parents on our panel. We had a panel with UNICEF, WHO, World Child Cancer pediatrician, but we had 2 parents on who also gave their experiences, and I think that made a huge impact on the audience. We needed more support, yes, and they've been part of a lot of things we've been doing. You can see some of our survivors on the information that you were given from World Child Cancer. They've been very vocal in the country with regards to advocacy. They were part of the team when we went to the First Lady. They've been involved in various things, our golf tournaments, our And we have patients actually as navigators. We have 3 of our survivors as patient navigators, so they're in the forefront of assisting other parents and other patients through the treatment cycle. Thank you very much. And I'd just like to also add that when it comes to creating awareness, we have animated videos in 6 Ghanaian languages, not only 1, but 6 Ghanaian languages, which we're using this season. Yes, and thank you very much.
And on the theme of national cancer control planning, I think there are lots of opportunities. So St. Jude has curated suites of more than 1,000 policies at the national level. We have screened from 5,000 plus, and it includes lexicons in 46 languages, and co-examining this with our wonderful advocates and those with lived experiences. So when we say NCCP ICAIA, the National Cancer Control Planning, integrating children, adolescents, and young adults, we're lucky to have many who have had lived experiences to participate and to join and to engage in those working groups with the ministries so that their voices and their perspectives are reflected. And as you noted, what we're looking at is, yes, definitely looking at the indices within the broader national plan, but increasingly through the efforts of CureALL and through the efforts of all the champions we have, there are many governments that are also developing separate pediatric cancer control plans that are integrated. So it's not about a separate plan that sits on a shelf, but having a separate dedicated plan for childhood cancer in addition to the elements that would be emphasized within the broader national NCD plan and health plan and cancer control plan, so that when we move forward with the priorities, whether thinking about financing, we have the people with lived experiences also being part of the implementation network and being part of the accountability framework, so that's the voices and the perspectives are held. But if you're interested in being co-researchers with us, please contact us and join the Next Post Network.
And just one final thing for me as well. I don't know if the microphone's working, but it's really important for us to have that representation at all levels. So one of the things that we've just recently done at World Child Cancer is to appoint a childhood cancer survivor from Sub-Saharan Africa to our board. So they'll be joining us later this year, which is, I think, just having it at all different levels of the organization. So from the strategic to the operational. So you've got that voice and that representation throughout the whole place.
Thanks for the wonderful presentations. Tezer Kutluk, a pediatric oncologist from Turkey and UICC past president. We all know that the limited health workforce in pediatric oncology is a major barrier, and it's getting worse. That's very well defined in this session, but I don't see a solution for the future. What do you suggest for solution of getting more young people interested in pediatric oncology? This is getting worse all over the low and middle income countries, although we show a lot of efforts.
Good question, Teza.
Well, I'll have a stab at answering that. I think for me, I've spent my whole career really looking after children with cancer and their families, and it's been a real privilege. I think it is very stressful from the workforce point of view, and from a National Health Service, it's obviously expensive to have a lot of doctors who only do that. And in many, many countries, it's paediatricians who have it as an interest. I think in terms of making it very attractive and enjoyable to the healthcare workforce, medical, nursing and others, you need to allow them to blend frontline clinical care with time to examine, reflect, do other aspects of the holistic support, whether that's research or, doing getting involved in other aspects of care. But I think there are many paediatric oncologists in the audience I can see, and I think the reason that we're all still here at the end of our careers is because we were research active and we had the privilege and the resources to be able to examine what we did, why we were successful when we succeeded, and also why we failed when we failed, and learn and then develop the next iteration of studies for that patient group. So I think I really do think research and kind of quality improvement work is something, it takes you away from the clinical frontline, but it's essential headspace for you as an oncologist and others to develop yourself. And the second, and maybe I'm looking at the Nigerian senior people, but I think salaries in government hospitals are a major issue in many low middle income countries. And I've seen colleagues in other countries who've got a high level of expertise and want to stay there, but they've been forced to move because they just couldn't, the salary was insufficient and they were too busy with oncology to earn enough money in general pediatrics.
Yes, thanks for that point, Kathy. And like I say, you could extend that over the whole of oncology, right?
Add our experience from India.
We only have 5 minutes.
We worked with Indian Academy of Pediatrics. And the pediatricians, while they are getting post-graduation training, we have inducted them with the help of SIOP. In 1998, the Practical Pediatric Oncology Workshop program, which is still running after so many years. And that really sensitizes them to the whole idea of being a pediatric oncologist. And this Practical Pediatric Oncology, it does 2 things. One is to sensitize pediatricians to pick up the cancers, pediatric cancers early and refer them to the right centers. And 2, shared care management. And 3rd, the students in pediatrics, they get sensitized and they get activated to take this as a super specialty training further down. And this has helped us to create so many pediatric oncologists down the line. Also help us to strengthen our Pediatric Hematology Oncology Society in India. And 3rd, today the pediatric oncology has been a recognized super specialty by National Medical Council. So these 3 things now has rolled out, and we have the privilege of having now pediatric oncologists dedicated through their whole career to pediatric oncology, not just by working in the field, but by choice and by training.
Thank you very much, Pranav. I think you wanted to say something, Luke?
It was just very, very quickly.
Yeah.
Princess, you go ahead.
Well, if people are happy to stay in the room, we can have another 5 minutes. Is anyone trying to come in the room?
So just one very quick point then. Sorry. Yeah, so I think one of the things you have to do to resolve this is obviously we have to make the training available to people, but crucially we also have to remember this is a career for many people. And so if you're going to train as a pediatric oncologist, but you don't have the resources, you don't have the staff, you don't have the medicines, and so what you're effectively doing is managing palliative care. It's a much less attractive career option for people than other things that are getting better funded. So you have to make sure the infrastructure is there so that when people join, they have a career they can see through.
Thank you so much. First of all, I'm a proud patron of SIOP as a mother of a cancer survivor. So I'm sharing my lived experience in many conferences with patients around the world as a carer of a child who has had cancer. And thankfully, he's well and everything is fine. And I'm a grandmother now, so I'm very happy. So I just wanted to pick up on what Kathy said about the issue of top pediatric oncologists who are studied in the US, Europe, etc. They don't have much incentive to come back because the salaries are ridiculous at government level. And we in Jordan, we had the same problem at the King Hussein Cancer Center when my child was being treated in the US. Before our center became amazing, I saw all of them in America, whether Palestinians, Jordanians, Lebanese, etc. And they would love to come back and really make an impact in their own country, right? In the US, they might be a drop in the ocean because there's so much expertise. But they couldn't, because at the end of the day, all these exams you guys have to do and study and what have you. And then, all you want, you're happy to take a drop in salary, but at least to be able to have a nice home in your country, put your kids in decent schools, right, etc. So why we managed at KHCC is because we were non-governmental. So what we did, our comprehensive cancer center, we were outside of the laws of the national health system. We were an NGO, and I always say that. So, that's why we could give the salaries that we think they should deserve. Because if we were part of the MOH, then they would say, so sorry, don't open that Pandora's box. If you raise this salary, you raise that salary, and then you have nobody. So sometimes, by the way, this is one final thing, when they tell us, support the health system, increase the health system in the country, sometimes my humble experience, is not WHO talk, is that sometimes countries, get one good center going, one comprehensive cancer center to focus, to be the magnet for all the top people, and then let let that center succeed and, give it the best that it should have to bring back all your top brains, etc., to come back to your country. And then it becomes the train that could. And so this is what happened with KHCC. Now, KHCC, King Hussein Cancer Center, because we managed to succeed, we train all the government hospital in oncology, whether radiologists, oncologists, etc. We are even helping managing a government department, sometimes bringing the whole health system up. Look how I'm saying it. It's so tiring. The whole
It's about leadership.
with cancer, get one cancer center up and going, and they can be the engine that could.
I've left UICC, but I'm still having to interrupt Princess Dina. I'm so sorry about that. You can tell how passionate she is, and so sorry we didn't have more time for more questions. Feel free to continue the conversations outside, and thank you very much for your attention. And thank you, our panelists.